Good morning or afternoon, everyone. So my name is Philly, and I'm a doctorate of public health candidate at the London School. But before I started that, I was the WHO lab coordinator in Liberia in the second half of 2015 and all through 2016. So that's what I'm going to talk to you about today. So I'm just going to talk a little about some of the challenges, especially the diagnostic challenges we had in Liberia. What progress has been made since 2015, and what are the remaining gaps that really need to be addressed. So, as we know, in West Africa, we were dealing with countries that had very, very weak health systems, and then Ebola basically, everything else stopped while we tried to deal with the Ebola outbreak. We know that the response was really slow because there was no in-country capability to actually diagnose Ebola in these samples. There was no molecular capacity, there were poor local staff expertise and training, and then there wasn't enough lab capacity even when we got international support, so there were delays in diagnostics. There was a heavy, if almost complete, reliance on international partner support, so partners coming in, setting up labs, and doing all of the diagnostics connected to the ETUs, the Ebola treatment units. We had poor, if any, specimen transportation systems. At the beginning, we had no rapid diagnostic tests. So some of the issues that Richard alluded to, we were facing the same challenges. There were no diagnostics then for other infectious diseases because actually, as I said, the whole health system stopped except for trying to deal with the Ebola outbreak. And then we had weak data management because in these countries, laboratory information systems and data management systems are often poor, if not non-existent. So in 2014, October 2014, WHO put together this target product profile for the ideal Ebola diagnostic test for this outbreak. And really there were just two viable diagnostic options. So it was either going to be a real-time PCR-based assay or an antigen detection assay that was a rapid diagnostic format. And they did receive a number of submissions and put those through this emergency use authorization procedure to try and get diagnostics out there into the field. A few were approved, however, they came quite late in the outbreak. So most of them were approved towards the end of 2014, but really in the first half of 2015 when the outbreak had already begun to wane. So one of those tests was the Cepheid Expert Ebola assay, which I'm going to talk a little bit more about today. So one of the issues we had in Liberia was that, as I said, there was this heavy reliance on international support, and as the outbreak waned and we had less samples or less positive samples, the partners started to leave. And so the operational lab capacity reduced from 11 operational labs to 3 in May 2015. Now this was a period between clusters, so we were still having outbreaks and clusters of cases. And between these outbreaks, we had periods of heightened surveillance. So you go through a period of 90-day heightened surveillance. So there were still huge amounts of samples being taken around the country. We were using the outbreak case definition, which meant that anybody with a temperature of 37.5 had to have an Ebola sample taken and tested. That meant all malaria cases. So you can imagine there were a lot of samples. So we didn't have the lab capacity to test all of these. So gradually, from about May to August, we had this build-up of samples in the system, which meant that we had no visibility in the surveillance system, so that we could have been having Ebola cases, but we couldn't see because we couldn't test the samples in real time. So when the Dutch government donated this mobile lab structure to the Ministry of Health when they left earlier that year. So we transported this to the ETU in Monrovia, and we installed 4 Gene Expert instruments. Now, you might be familiar with Gene Expert from TB diagnostics and also HIV viral load, but Cepheid actually manufactured this Ebola assay during the outbreak, and as I said earlier, it got WHO emergency use authorization. So we trained local lab technicians, so Liberian lab staff, and installed the instruments and started testing. The test is easy to use, requires minimal training, minimal PPE once you have a glove box, which we did in the container, and results are available within 90 minutes. It also has a really good sensitivity and specificity because it's real-time PCR, and all of the reagents are contained within the little blue cartridge that you can see there. Cost comparison to conventional PCR was about the same, about $20 per test, and that was supported by FIND and WHO. So this graph kind of shows the impact on the surveillance system. So you can see the red line shows the testing capacity in country. It was about 180 until the end of September when we established the lab with the mobile lab with the Gene Experts. Then it increased to 250. And you can see this was a period between 2 clusters of cases, so the Margibi cluster and the Duport Road cluster. We were in that period of heightened surveillance where there were a huge amount of samples being taken. So this really helped with testing all of those backlog of samples, and within about 4 weeks the backlog reduced. And then a couple of weeks after that, we actually detected the next cluster of cases at the lab. So this was a routine specimen that was submitted from a patient who was in the tertiary hospital in Monrovia, which is the capital city. He was a 15-year-old boy who was in a pediatric ward, in an open pediatric ward with other patients, sharing toilets with other patients. He was being treated by staff without PPE, even though we were still in an Ebola outbreak technically, and his family were looking after him in the hospital. So all of the family and him were immediately transferred to the ETU, and then those who were negative were held in the suspect ward, and him and 2 other family members were in the confirmed ward. And then we could monitor the patients, so the confirmed cases. So if you're familiar with PCR, you know that the cycle threshold value gives an indication of the viral load in the sample. So we knew that if the CT values were increasing, then that meant that the viral loads were decreasing and that the patients were recovering. So you can see that clearly in the graphs for the 2 clusters. The Duport Road cluster, which we had in November 2015, and then the next cluster in April 2016. So the lab was really useful, and the Gene Expert assay was, had a huge impact on managing both of those clusters, detecting both of those clusters, and then also supporting the contact tracers in the community. So rather than bringing all of the patients who fitted the case definition into the ETU and put them in the suspect ward, we could do field blood draws and submit the samples, have results back within about 2 to 3 hours, and so there was no need to transfer the patients to the Ebola treatment unit. Just to mention that this was a huge effort of coordination and partnership, so involving many different organizations, including FIND, WHO, the Ministry of Health, obviously, Excel, CDC, Riders, and eHealth Africa. And the lab was operational for 1.5 years, testing over 10,000 samples over that period. So we also felt that this was a contribution to lab system strengthening, because this technology is sustainable to a degree in Liberia in that it requires minimal training. We could train local Liberian staff to be trainers of trainers, so to keep that going. And then all of the reagents are contained within the cartridge and could be stored at room temperature. The instruments, once the lab was decommissioned, the instruments were redeployed to support EVD isolation units that were being built at different hospitals around the country. And we were also started to use them for HIV viral load testing and for TB, to support TB clinics as well. Another intervention towards, well, probably mid-2015 as well, we started to use these rapid diagnostic tests, which started to be approved by WHO. And the one that we used in Liberia was the Aura Quick. So we used it to test dead bodies as a negative screening test. So basically the tests were performed by the burial teams who went out to respond to deaths in the community. They could swab the body and have a result within 30 minutes. If that was non-reactive, then the body could be returned to the family for a family burial, as opposed to these safe and dignified burials, which really weren't very dignified. And if they were reactive, which we did have one reactive, but it was actually a false positive, and that did create a bit of chaos because obviously the emergency response mechanism kicks in. But overall, I think it was very positive, and we have some validation data now for future outbreaks. I mentioned earlier that we had issues around specimen transport, so you can see from the photos there that we have some very challenging road conditions in Liberia in rainy season. So we funded this organization called Riders for Health, who are a social innovation funded through WHO TDR. And they're motorbike couriers who carry these cooler boxes in backpacks on their backs, and they carry the specimens. So they use this hub and spoke network where riders bring it to the depot, and then it's collected and brought onto the labs. And we started to use that for Ebola, but then also for other specimens once we started to get the diagnostic system back up and running. Next generation sequencing was also used more towards the end of the outbreak, so for the last few clusters especially, to support the case investigation and the epidemiological investigations. So, as I said, we didn't have a lot of testing for other diseases, even malaria. So people were dying of malaria and, diseases that were perfectly preventable. And as you know, Lassa fever is, well, maybe you don't know, but Lassa fever is endemic in Liberia, in West Africa, and Liberia specifically. And in February 2016, we had an outbreak at the UN military base. But we had no in-country diagnostic capacity. So before Ebola, the specimens were referred to Kenema, which was a Lassa fever, regional Lassa fever lab in Sierra Leone. But we had this moratorium on international samples, so nobody was accepting samples from Liberia because it was an Ebola-affected country. So we had to reinstate that relationship and try and get approvals and build that system. To get those samples tested while the outbreak investigation was going on. And then we started to try to build capacity to test at the National Reference Lab in Liberia. So what has happened since 2015 and what progress has been made globally? We know that WHO didn't handle the outbreak very well and maybe were quite slow to respond, and the coordination was not up to scratch. So as part of WHO reform, they've established the WHO Health Emergencies Programme, and this is specifically to deal with emergencies with public health issues. There are a number of departments that are focused specifically on laboratory support and diagnostic support, so I think that's really positive. We also have a number of countries building international rapid response teams who can actually go and rapidly respond to these outbreaks in real time. One of those is the UK Public Health Rapid Support Team. It might be the only one that's actually active globally at the moment. But this is a partnership between London School of Hygiene and Tropical Medicine and Public Health England. And they have a triple mandate to integrate outbreak response, operational research in these responses to find better ways to respond and to improve the responses, which I think is key, and capacity building to help these countries to actually be able to respond themselves. At a national level, then, I know it's happening in Liberia and Guinea and probably Sierra Leone, but these countries are developing their own capacity in the form of national public health institutes so they can respond to public health emergencies. I think that globally we're seeing definitely raised awareness and commitment to laboratory support and coordination. So we're not just something that comes under EPI, we are actually a really important pillar of a response ourselves. And I think there's more awareness around the need to build resilient lab systems in these countries. So, with proper quality management systems, proper biosafety, so that we actually have the capacity to detect and diagnose and respond themselves. And there's also greater awareness around the need for better research and better data sharing, which is positive. We now have the WHO Blueprint, which is a list of diseases and pathogens to prioritize for research and development in public health emergencies. So they're diseases of epidemic potential for which there are no or insufficient countermeasures. And Ebola, Marburg, and Lassa are all listed on there. And we now have the Ebola Research and Development Roadmap, which is available for comment. In the current Ebola outbreak in the Congo, we're seeing that the gene expert was used as one of the primary diagnostic methods. So they had rapid results to support case investigation and contact tracing, and integrated the lessons from West Africa, which I think is good. And we also saw that Cepheid were able to actually rapidly manufacture these assays and send them out and get them into the field when they were needed. So I think there's still a number of gaps and needs. There's an ongoing debate around the need for biobanks. We heard some of it this morning, but specifically in these countries, I know in Liberia, there are many freezers full of Ebola positive samples, Lassa positive samples that are stored in far from ideal conditions, in dodgy freezers with dodgy generators that run out of fuel regularly. So besides the biosafety and biosecurity issues, I think that there are issues around the fact that there's so much information and knowledge to be garnered from these specimens that's just not being capitalized on, and can't be until we agree, a reasonable way to share these samples. It's Ebola, Lassa, both are NTDs, so there are weak commercial markets, so we need to incentivize this research and development so that we can get these tests manufactured so that they're available when we actually need them to deploy to the field. There's a global lack of BSL-4 containment facilities for this R&D to happen. And then there are issues around the rapid scale up of these assays. Even if we have them, how can we get them produced in time to get them into the field to respond to an outbreak? If it's going to take 6 weeks, then maybe the outbreak is over by the time we actually get the tests into the field. Lassa fever diagnostics are always a challenge because we have a geographical strain variation, so it's very difficult to even develop rapid tests. So these are often deprioritized. And then there are serious issues around data management and laboratory information systems in these countries, which are often non-existent. So I'll leave it there. Sorry, it's a bit of a whistle stop, but I hope that I've raised some issues that we can maybe discuss further in the panel discussion. So thank you for your time.